incoordination of the upper and lower limbs, causing falls, and patient has positive abnormal finger nose testing and Hilton testing, and they may have intentional tremor. They can have dysarthria and nystagmus. The second pathway which causes ataxia, that is not cerebellar ataxia, that is sensory ataxia, and it is different from cerebellar ataxia. Sensory ataxia is basically caused by loss of position sense, and the position sense loss, it can be caused by large fiber neuropathies or lesions of the dorsal spinal cord, dorsal roots of the spinal cord, posterior spinal cord issues, and it is characterized by ataxia of the gait and even ataxia of the limbs, and it is more prominent when the visual cues are lost, like in the dark environments. And on examination, you will find loss of proprioception, and if the lesion is in the peripheral nerves, that is the large fiber neuropathy, there will be absolute hyporeflexia or areflexia. Either the reflexes will be reduced or these will be absent, and there will be positive rhombus test. When you ask the patient to stand on a narrow stance with eyes closed, with open eyes he can stand. When you close the eyes and you remove the visual cues, the patient tends to fall. So that is loss of position because of loss of proprioception, sense of proprioception, and that is not because of cerebellar dysfunction. These patients, they do not have nystagmus or dysarthria. That is a characteristic of cerebellar ataxia. Regarding the structure of the cerebellum, it has a midline structure that is called vermis, and lesions of the vermis, these called dysarthria, truncal deturbation, that is truncal ataxia, and gait abnormalities, wide-based gait, ataxic gait. And then there is lesion in the hemisphere. Now always remember that the hemispheric lesions, they give rise to ipsilateral findings because the tracts are double crossed. So the findings will be ipsilateral toward the side of the involved hemisphere. There will be limb dysmetria, that is limb incoordination. Again, finger, nose, and Hilton test will be impaired, and there will be ipsilateral veering while walking. It means that the patient tends to fall towards the involved side, and there can be intention tremor, and then can be hypotonia, and also nystagmus and dysarthria. So the clinical assessment is complicated by the fact that few ataxic patients have pure cerebellar disease, and they have additional involvement of the nervous system, additional involvement of different other parts of the nervous system like brainstem and spinal cord. And ataxia also may be caused by weakness, so you have to be very careful when you are commenting on cerebellar ataxia in a patient who has significant motor weakness, because due to motor weakness he will not be able to perform the finger, nose, or Hilton test properly. As far as the etiology of cerebellar ataxia is concerned, we divide the causes into acquired and into hereditary causes. And the hereditary causes, either these can be due to a known metabolic defect, or this can be because of some unknown metabolic defect. Acquired causes include posterior fossa abscess, and patient, they can develop posterior fossa abscess secondary to infection in the ear like suppurative otitis media or some hematogenesis spread, and they do present with headache, signs of raised ICP, fever, and the cerebellar signs, and they can even develop altered mental status because of raised ICP. Then we have cerebellitis. Cerebellitis is usually a para-infectious or post-infectious inflammation of the cerebellum that is usually due to viral infection, and it's more common in children, and especially after the viral exanthemes like chickenpox, measles, and they present with all the sign and symptom of cerebellar disease of ataxia, nystagmus, dysarthria, and this is usually a self-limiting disorder, and usually it does not need much treatment, and the recovery is almost always good. Then we have vascular disorder, which include hemorrhage in the cerebellum, or infarction, or maybe posterior circulation, TIAs. The hemorrhage in the cerebellum, as I've already explained, that if there is hemorrhage towards one side of the cerebellum or infarction involving one cerebellar hemisphere, the findings will be unilateral. Patient will have unilateral limb ataxia or limb dysmetria, what you call, and If the hemorrhage is there, patient may have headache, or they may develop raised ICP and hydrocephalus. And same is true for infarction. If it's a big infarction, it can later on develop edema and hydrocephalus and altered mental status as well. Then come demyelinating disorders like multiple sclerosis. And then we have malignancies like tumor, and they will also again give you unilateral signs and symptoms. And then we have toxins and drugs. Now remember that toxins, drugs, and metabolic causes and paraneoplastic, these give you bilateral signs. These do not give you unilateral. When the signs are unilateral, always think about infective causes or vascular causes, or maybe demyelination or neoplastic causes like malignancy, primary or secondary brain tumors, either mass or primary brain tumors. Toxin drugs include antiepileptic drugs like phenytoin, and we have certain chemotherapeutic agents like cytosine, arabinoside, and cyclosporin, and it will be evident from patient's history. And paraneoplastic can be associated with small cell C of the lung or other malignancies. And metabolic vitamin E deficiency can give rise to cerebellar ataxia and also hypothyroidism, and these are the reversible causes. Then we have hereditary causes, which we divide into known metabolic defects, and the known metabolic defects can either be due to DNA repair defect, or either these can be due to unknown etiology. And then we have hereditary known metabolic defect, which can be intermittent, with intermittent sign and symptom like episodic ataxia, or these can be progressive with progressive cerebellar dysfunction. In hereditary causes, ataxia is a prominent feature, and causes of intermittent ataxia include hyperammonemia. These are the metabolic disorder, basically amino acid urea, and disorders of pyruvate and lactate. And in progressive disorders, we have A-beta lipoproteinemia. Now, this is a hereditary disorder, and ataxia is not the only feature of A-beta lipoproteinemia. Patients, they have signs and symptoms of malabsorption with diarrhea and weight loss, and they also develop neuropathy, and along with that, they can develop visual symptoms, retinopathy as well. Then we enter leukodystrophy. Leukodystrophy, these are white matter disorders, and these are dysmyelinating disorders. These are not demyelinating, this is rather dysmyelination, and these are usually start in early childhood or early adulthood. Some of the leukodystrophies, they can manifest later in the later elder age groups, while mostly these are present in children and young adults or adolescent age. And in leukodystrophies, there are other features also along with cerebellar ataxia. There can be regression of the motor milestones. And what is meant by regression of motor milestones? That the child who has acquired the milestones of walking, running, and good mentation, and all of a sudden he starts deteriorating. Like he stops walking, he has recurrent falls, then he becomes bad bound over time, and there is cognitive impairment. So these are the leukodystrophies, and unfortunately there is no cure for these leukodystrophies. These are neurodegenerative disorders. These are white matter degenerative disorders. Then the other group is mitochondrial encephalomyopathy. Now, mitochondrial encephalomyopathy is a big group, wide group of disorders. These are maternally inherited disorders, and there are so many disorders encompassed under this heading. And one of these is Kearns-Sayre syndrome, and they are very difficult names which you don't need to remember. Just remember that these disorders, they can present with cerebellar ataxias, and they can present with epilepsies like myoclonic epilepsy, and they can present with a stroke-like episodes, with different manifestations associated with different disorders in this group. And these are maternally inherited disorders, and second, they can present with proximal muscle weakness. That's why the word encephalomyopathy is included. There can be even cognitive impairment. Then other disorder is Wilson's disease. As you all know, this is copper metabolism disease, and it is also manifested in a younger age group, and it is autosomal recessive disease. Family history can be present, and patients, they usually start developing the symptoms like decreased cognition, difficulty in speech, difficulty in swallowing. They have dystonia, they can have Parkinsonian symptoms, they can have abnormal movements like chorea, they can even have cerebellar ataxia as a part of their disease. So you can see that none of these diseases has pure cerebellar symptoms. There is a spectrum of symptoms, and cerebellar ataxia is a part of it. Again, we have sialidosis, again an inherited disorder. Cerebellar ataxia is one of its features, and the other features are myoclonic epilepsy, and in some patients there is mild cognitive decline also. And there are some other rare disorders like hexosaminidase deficiency or sphingomyelin and ceroid lipofuscinosis. So there's no need to go into the details of these. Then we have defective DNA repair disorder, and one of these is ataxia telangiectasia, and we will learn something about ataxia telangiectasia. Then we have other rare disorder like xeroderma pigmentosum, in which there is skin manifestation, and cocaine syndrome is another rare disorder. So the hereditary ataxias with unknown etiology, and these can be either autosomal recessive or autosomal dominant. Now the autosomal recessive disorder, they have more severe disease and the onset is earlier, that is less than 20 years, and the dominant ones, they usually start after 20 years of age. Now we divide the autosomal dominant cerebral ataxias into three groups: ATCA1, ATCA2 and ATCA3. Now the first group, that is the autosomal dominant cerebral ataxia 1. What other features they have along with cerebellar ataxia? They can have ophthalmoplegia, they can have optic atrophy, they can have dementia, and they can have extrapyramidal feature like rigidity and bradykinesia and Parkinsonian features. See, this is a group. There are so many cerebellar disorders, so many genes identified in this group. And then we have another group. These are common feature of group 1. And then ATCA2, it is characterized by cerebellar ataxia with pigmentary maculopathy that is causing vision problems. They may have ophthalmoplegia and they may also have extrapyramidal signs. So here we have ataxia with vision disorders, pigmentary maculopathy. And in the first group, we had ataxia with either optic atrophy or maybe ophthalmoplegia, dementia, extrapyramidal features. Now the third group is pure ataxia. They do not have any other signs except pure cerebellar ataxia, and the last one is periodic dominant ataxia. The investigations that we do are to rule out the acquired causes, and regarding the acquired causes, you can get clues from the history like the drugs, the toxins, and alcohol abuse, and you can get CT and MRI also in certain cases, and CSF analysis also can help, like in maybe in MS or maybe in cerebellitis, to give you some mild lymphocytic pleocytosis, slightly raised protein, and EMG NCS when you are suspecting sensory ataxia. Either you are suspecting simple sensory ataxia or you are suspecting along with peripheral nerve involvement along with cerebellar ataxia. Thyroid function test and hypothyroidism is one of the cause, and lipid profile, there will be low LDL in patient with A beta lipoproteinemia. Now we will talk about Friedreich's ataxia, that is a relatively common form of autosomal recessive ataxia, though it is also rare, and it's the most common of autosomal recessive ataxia. 50% of hereditary ataxias are Friedreich's ataxia. The gene maps to chromosome 9q13, and it is a trinucleotide repeat disease. Now here again, it does not affect cerebellum only. It affects the nervous system, the heart, the pancreas, and the onset is slow and progressive. The pathology involves spinal cord, posterior columns, which is causing loss of proprioception and loss of reflexes, corticospinal tract, and with advanced disease, patient they can develop motor weakness, and they can also develop pyramidal signs, that is positive Babinski signs or extensive plantars. It can involve spinocerebellar tracts, which causes ataxia and dysarthria. It can cause loss of Purkinje cell in the cerebellum, pontine medulla and optic nerves, so optic atrophy can be present, and peripheral nerves can be involved, loss of reflexes can be there, myocardial muscle fiber, they can develop cardiomyopathy, and 10% of these patients, they develop diabetes also because of involvement of pancreas. Onset is usually before 25 years. It begins as get ataxia early. Dysarthria is a later feature, and patient can have cerebellar ataxia as well as sensory ataxia. There may be peripheral nerve involvement. There can be motor weakness, as I told you, due to corticospinal tract involvement. And optic atrophy is present in 25% of the patients, and then they can develop decreased vision. deafness in 10%, and diabetes also in 10%. On examination, you will get face cavus, that is the high arched foot, hammer-toes, and spine deformities like kyphoscoliosis, and they may have heaving apex feet because of hypertrophic cardiomyopathy. There can be decreased or absent reflexes, loss of vibration and position sense, positive Babinski sign, that is extensor plantar, and patients can have all the cerebellar sign, and rhombus can also be positive. So this is the symptom complex of Friedreich's ataxia. We do see such cases in our clinical setting, but not very commonly. Then we have ataxia telangiectasia. It is also a very, very rare disorder, and I've hardly seen maybe 2 cases till now. And the gene is mapped on 11q22. The incidence is 1 as to 20 to 100,000 of the population. It is causing DNA damage. The gene involved, the ataxia telangiectasia gene, which is involved, plays a role in the cell cycle progression. The neurological features of ataxia telangiectasia include progressive cerebellar ataxia, which is the earliest feature. As soon as the child starts walking, and then they have problem with fluid walking, they cannot walk unaided, or they cannot walk smoothly. There can be dysarthria, that is the articulation problem. Patient, they may have abnormal eye movements. They can also have dystonia, chorea, and peripheral neuropathy. Again, you can see this is not a pure cerebellar disorder. So again, we can see telangiectasias can be present. These are the dilated arterioles, vessels, which can be present in the sclera, on the nose. We can have it on the face, on the earlobes, and they appear at the age of 3 to 5 years, and they can also have caffeoline macules. That's the brownish macules present on the body. And these patients, they can also, they are immunoglobulin deficient, so there is an immunodeficiency, which results in recurrent sinopulmonary infections. They can have recurrent upper and lower respiratory tract infections. In these patients, they can develop pulmonary disease, which is a major cause of death in these patients. Patient can have recurrent infection, they can have interstitial lung disease, they can have neuromuscular abnormalities leading to dysphagia and aspiration pneumonias and respiratory muscle weakness. And these patients are prone to develop malignancies. 10 to 20% of ataxia telangiectasia patient can develop malignancy over time. So this was about ataxia telangiectasia. These are a little difficult because these are rare disorder and they don't have a single symptom which can categorize that this is cerebellar or this is called lesion. No, this is a symptom complex. Whenever these hereditary disorder and these syndromes, they have always a symptom complex, not a single symptom. Now, how would you identify the cause of ataxia in any patient? And the identification starts right from your history. When the history is acute, the cause is likely vascular or maybe sometimes toxins. And when it is subacute, then become other causes like infection, inflammation, demyelination, tumors, and then the course. If it is episodic, it can be MS, it can be TIA, it can be certain drugs which patient take intermittently, and sometimes what happens that there is a colloid cyst with intermittent hydrocephalus. That is also a cause of ataxia. And foramen magnum compression, sometimes when there is intermittent compression, it can lead to intermittent ataxia. And inherited metabolic disorder, as I told you, they are associated with episodic ataxias, and one disorder which is dominant periodic ataxia is also a cause of episodic ataxia. Then come progressive causes. These can be inherited. It can be because of a slowly growing tumor and paraneoplastic, vitamin E deficiencies, and also multiple sclerosis. And some patient in primary progressive MS, the disease will be progressive, while in the relapsing remitting MS, it will come in episodic ataxia, that is relapsing and remitting MS. In the systemic manifestation, for example, in the eyes, if you get Kessler-Fleischer ring, that is a greenish brown deposition at the limbus, that is suggestive of Wilson's disease. If you find cataract, think about mitochondrial encephalopathies, or if the patient has fever, think about abscess or cerebellitis. If the patient has vomiting can be a manifestation of hemorrhage or a tumor or raised ICP. can be infections even in some metabolic disorder like amino aciduria. When there is hepatosplenomegaly, think about Wilson's. This is how you go, systematically compiling all the sign and symptom and history in your mind. If the patient has cardiomyopathy, think about Friedreich's ataxia. If the patient has conduction blocks, think about mitochondrial encephalopathies. Then the diagnosis. Diagnosis is mostly clinical. Then come to the labs. Diabetes mellitus is present in 30% of the patients, and this is about Friedreich's ataxia, not for all. Okay. In clinical presentations, opsoclonus. Opsoclonus can be a feature of viral cerebellitis and paraneoplastic cerebellar ataxias, and opsoclonus is basically a very rapid, random movement of the eyeballs in variable directions. I wish I had a video to show you, but you can check it on YouTube. It's a very particular eye movement disorder which is present in either the paraneoplastic or in viral cerebellitis patient. Then we have extrapyramidal. Extrapyramidal feature can be present in ataxia telangiectasia, some late onset ataxia that were the autosomal dominant type, and also in Wilson. Any patient who has young onset Parkinsonism, you need to rule out Wilson's disease. Young onset Parkinsonism, as a rule, you have to rule out Wilson's disease by doing the workup like LFT, serum ceruloplasmin, 24 hours urinary copper excretion, and examining the KF ring with the slit lamp. So this was a good point to share. Then we have myoclonus. If there is myoclonus, think about either the mitochondrial encephalopathies or stalidosis. Now comes hyporeflexia. Now hyporeflexia, we need to think about those conditions which can give rise to diminished reflexes either because of the dorsal root involvement or because of the peripheral nerve involvement concomitant with cerebellar ataxia. As I've told you, there is most of the time a symptom complex, so you need to take into consideration all your neurological findings and taking clues from those. Loss of proprioception, hyporeflexia, either it can be Friedreich's ataxia, any other degenerative disorder in which there is associated neuropathy, vitamin E deficiency, even hypothyroidism can give to decreased reflexes, and alcohol, and also Miller-Fisher. Now in Miller-Fisher syndrome, which is a variant of GBS, patients mainly they have sensory ataxia, but sometimes they do have cerebellar ataxia. In leukodystrophies, there can be associated neuropathy. Reflexes can be diminished, not overall, maybe ankle absent is diminished. Ataxia telangiectasia, again, there is associated neuropathy, so there may be hyporeflexia. And xeroderma pigmentosum, they may also have associated neuropathy as well as Refsum disease. Then if the patient has deafness, think about inherited ataxias, think about mitochondrial disorders, and think about Refsum's disease. Then if there is dementia, think about some neurodegenerative disorder, and also cognitive impairment can occur in Wilson's disease and also in patients with hydrocephalus. Optic atrophy if present, you should think about Friedreich's, multiple sclerosis, inherited causes, and alcoholism. If there is retinopathy present, think about mitochondrial encephalopathy. Now the systemic manifestation which gives you clue about the underlying cause: hair loss, hypothyroidism. Skin telangiectasias in the nose, earlobes, and conjunctiva, think about ataxia telangiectasia. If the patient has light sensitive, think about xeroderma pigmentosum. If the patient has dry skin, think about Refsum, hypothyroidism, and Cockayne syndrome. If the patient is immunodeficient and he is developing recurrent cyanopulmonary infections, think about ataxia telangiectasias. Malnutrition, maybe vitamin E deficiency, maybe alcoholism. Skeletal deformity either can be Friedreich's ataxia or other early onset spinocerebellar degeneration or the hereditary sensory motor neuropathy. But in hereditary sensory motor neuropathy, the ataxia will not be cerebellar, it is sensory. So we don't keep this here. Hypogonadism can be present in mitochondrial encephalomyopathies or ataxia telangiectasia. Now, what for acute ataxia? The patient they come with acute onset ataxia. Neuroimaging is always mandatory, and especially if the patient has altered mental status or they have focal neurological signs, they have other brainstem signs like cranial neuropathies or they have marked asymmetric ataxia, you are finding unilateral signs of the cerebellar dysfunction, and history of trauma, or their concern of mass lesion like posterior fossa symptoms. They have headache, vomiting, and papilledema is present, or you may get nerve palsies like 6 nerve palsies due to raised ICP. MRI is best, especially for posterior fossa lesion and demyelinating, because it's a small deep-seated structure, and sometimes you can easily miss posterior fossa lesion and demyelination in small posterior fossa tumors. In CT, if concerned for hydrocephalus or trauma or mass lesion, or the patient is unstable to go for MRI because MRI takes time, CT can be done within few minutes, and you can urgently get it and have a baseline idea of the underlying problem. If the CT is normal, definitely you have to go for MRI. And for the lab testing, acute ataxia, as I told you, can be because of intoxication, so you can go for drug screening on alcohol levels, and CSF if you are concerning infection or Miller fissure. But be careful about CSF if you are thinking that the patient has papilledema or sign and symptom of raised ICP. And Miller fissure syndrome, yes, CSF can help because it will show albuminocytological dissociation. And when you are looking for degenerative ataxias, you can look for lipids like an beta lipoproteinemia, and MRI brain, yes, it is indicated, and alpha fetoprotein in late onset ataxia, no, in young onset ataxia, yes, less than 20 years. IgG levels, that can be decreased, and ataxia telangiectasias in younger patients, these are advisable. Then we have ACTH and very long chain fatty acid level, that is for adenoleukodystrophy, and you can get it done if you're suspecting adenoleukodystrophy. Ceruloplasmin, yes, you can order it in patients in whom you're suspecting Wilson's disease. And for Wilson's disease, please be careful that these patients can present to you up to 50 years of age, and sometimes in rare cases even beyond 50. So you need to consider Wilson's disease. And whenever you are seeing a patient who has young onset dystonia, young onset Parkinsonism, cognitive impairment, and tremors, or young onset abnormal movements, any sort of abnormal movements. And lactate can also have lactic acid level that is raised in mitochondrial encephalopathies. And then we have genetic disorder in which we need genetic studies, and unfortunately many of these genetic studies are not available in Pakistan, and these are very costly, and some of the institutes, they send the samples to other countries for testing. It can be done if the patient can afford and to make a diagnosis and for genetic counseling. So this was all about approach to the cerebellar disorders. I hope I made it clear, and it was little difficult because there were difficult names and you may not have heard about these diseases before, but it needed to be included. So I hope you got the clue that how to approach a patient of ataxia, how to take clues from the history and neurological examination, and from the systemic examination, and family history is so much important, and patients' complete detailed history examination is so much important before you proceed for fancy investigations. So this was about cerebellar ataxias, and Allah Hafiz till next class. If you have any queries, you can post it, and inshallah I will answer. Thank you.